Thank you, Pepe. Thank you very much. Please stay online for the discussion at the end of the session. So we're going to move now to the next speaker, who will be Dr. Jaime Kulizki from the Santa Creu Santa Pau Hospital in Barcelona. We'll talk about hallucinations in Parkinson's disease, clinical and neuroimaging correlates. Jaime, you have the floor.
Yes, okay. Then thanks to the organizers to invite me to give this lecture. And then in the next 25 minutes, I will talk about hallucinations in Parkinson's disease and making a special mention of the differentiation between major hallucinations and minor hallucinations, the prognostic implications of hallucinations in Parkinson's, mainly in relation with cognitive impairment, neuropsychological and neuroimaging correlates of hallucinations, especially in non-demented people with Parkinson's disease, and a specific focus on minor hallucinations, whether they represent or not a bad prognostic implications for people with Parkinson's disease. Hallucinations in Parkinson's are very frequent, can involve any sensory modality, but most commonly occurs as visual hallucinations. Retaining insight is characteristic of the early phases of hallucinations, but with the progression of the disease, there is a loss of insight in advanced phases, especially in patients with cognitive impairment and dementia. Characteristically, the affective component is absent in patients with Parkinson's disease, and they appear not concerned or emotionally implicated in the hallucination. This is a typical example of a patient with hallucinations. She can explain without any affective concern that she is seeing a man, for instance. And many times these hallucinations even can have a pleasure component, but typically they are also repetitive. That is, people can complain about the same hallucination. Importantly, having hallucinations is presently the strongest single predictor of dementia developing in a patient with Parkinson's disease. And having visual hallucinations, especially major visual hallucinations, the risk of developing dementia increase up to 20 times regarding patients without hallucinations. However, hallucinations also appear and are very frequent in non-demented patients with Parkinson's disease. This is a study that we made some years ago. It's a big sample of non-demented patients with Parkinson's disease, and up to 17% of these non-demented patients had hallucinations, mainly major and minor hallucinations, and they were associated with more depression, with more apathy, and 43% of this sample had also cognitive impairment, not dementia, but some degree of cognitive impairment. The same was observed in other series. This is a big sample also, and more or less the frequency of psychotic phenomena in the form mainly of visual hallucinations is a little bigger, and these hallucinations were associated again with depression and also with REM behavior disorder. The lifetime prevalence of visual hallucinations are present mainly, this is the classical idea, on the second half of the disease, and is increasing in periods of 5 years until 60% in patients after 20 years of the disease. This is from a classical study of Getz and collaborators. But this data was largely collected on patients suffering well-structured, that is, major hallucinations, and prevalence would appear underestimated if the full spectrum of psychosis is to be considered. These are regions of cortical atrophy in patients suffering from PD psychosis. And again, this was studied mainly in patients suffering structured major visual hallucinations. But you can see that there are alterations associated with widely distributed regions of atrophy, but specific regions also of cortical atrophy, mainly cortical atrophy of complex visual and sensory processing areas. From a functional and metabolic point of view, there is decreased activity in extrastriatal and visual cortex, and decreased metabolism in temporoparietal and occipital areas. That is, if we integrate these data into models, there is an alteration of regions of the dorsal visual stream, that is the portion that determines where is an object, and also of the ventral visual stream, that is the portion that determines what is the object. And mainly of areas structural and functionally related with the default mode network, including the dorsal visual stream and more complex perceptive areas. And this alteration of the default mode network was studied some years ago, mainly by the group of Shine, and we can see that the proposal is that major visual hallucinations are due to a relative inability to recruit activation in the dorsal attentional network, leading to an over-reliance on the ventral attentional network and on the default mode network. You know that these circuits or these networks are anti-correlated, and when you activate, for instance, the executive attentional network, you have to deactivate the default mode network. That is, impairment at multiple levels of this neural architecture would ultimately manifest as a hallucinatory behavior because of this over-reliance on the default mode network. What about minor hallucinations? Minor hallucinations are mainly defined by sense of presence and passage hallucinations. That is, the patient complains that he or she feels that there is someone on the back, or that someone is passing through the periphery of the visual field, or that there is a presence that is fully defined, maybe in his or her back. And these minor hallucinations were suggested some years ago by Fenelon, that they are the most frequent and early type of psychotic phenomena, and some works from Fenelon seem to point in that direction. And applying new criteria or recent criteria by the MDS, minor hallucinations appear integrated in a continuum of psychosis in Parkinson's disease. That is, they are accepted to be part of these psychotic phenomena or manifestations of Parkinson's disease. We recently conducted a meta-analysis to identify articles focusing on minor hallucinations, and there are not very many of them. But we observed that although called minor hallucinations may have major clinical and prognostic implications, but the actual prevalence and the underlying neurobiological changes of minor hallucinations remains largely unknown. And then further research are needed to establish whether they represent a higher risk of major hallucinations, of cognitive deterioration, or of a more accelerated disease progression. This is a typical patient with minor hallucinations.
Tiene la sensación de que nota a alguien que pasa por su lado.
A veces noto como una sombra, depende de lo que hay alrededor. Me imagino que es una persona, o puede ser un objeto, o puede ser un animal, también puede ser de diferentes tamaños.
Y usted tiene la sensación de que haya como una persona, un objeto, un animal que pasa.
Que me viene de atrás hacia adelante.
Yeah, this passage from the back to or to the side of the visual field is very, very typical. It is poorly defined by the patient, but the patient feels that there is a presence. Importantly, this was a patient until not treated. This was the novel patient that is having minor hallucinations before treatment. And then we conducted a study studying 50 patients, drug-naive, the novel patients, and 100 controls, specifically addressing for the presence of minor hallucinations. And we disclosed that minor hallucinations in 42% of these de novo patients with Parkinson's disease, even in 5% of controls. Interestingly, 1/3 of these patients with minor hallucinations had the phenomena as a premotor manifestation of the disease, starting 7 months to 8 years before the appearance of the first Parkinsonian motor symptoms. That is, there was the most frequent were passage and presence hallucinations, and there was an association, a significant association with REM behavior disorder. Interestingly, we follow these patients, and 52 of the patients remain stable with the minor hallucinations, even a percentage improved initially and worsened later, that is, again presented minor hallucinations. 20% developed well-structured hallucinations, and 25%, 1 in 4, cognitive deterioration, with 14% developing dementia. We studied from a neuropsychological point of view, which was the difference between minor and major hallucinations in this prospective study. And we observed, curiously, that there is no difference from a neuropsychological point of view, or there were no difference between patients with and without minor hallucinations. But patients with major hallucinations and insight retained were worse on executive tasks, and patients with major hallucinations and some antecedents of loss of insight exhibited an additional worsening on posterior cortical tasks. That is, there was a comprehensible continuum of clinical deterioration in cognition among minor, major, and major hallucinations with loss of insight. We then studied the neural correlates of these minor hallucinations in non-demented patients, and we observed that there were a gray matter volume loss affecting, again, the dorsal visual stream and functionally related areas of visual processing and spatially guided behaviors, such as the cuneus, the superior occipital gyrus, the midbrain colliculi, and the right precuneus. That is more or less similar to the alterations observed in patients with major visual hallucinations. And the gray matter volume loss was particularly observed in the precuneus and functionally related areas of the dorsal visual streams, that is affecting heteromodal and integrative perceptive areas. The precuneus is interesting because this is mainly involved in the integration of visuospatial imagery, in the processing of self-centered mental imagery strategies, and helps to separate formation of body image from the external space. That is one of the alterations of patients with passage and presence hallucinations. But what about functional studies in patients with minor hallucinations? And these type of studies are lacking. And theoretically, at least, functional changes can precede structural atrophy in neurodegeneration. Then we conducted this other study, studying 32 patients, non-demented, 18 with isolated minor hallucinations, 14 with no hallucinations. And we again repeated the structural analysis, but also a functional connectivity comparative analysis using resting state fMRI. And then we observed in the structural analysis more or less the same as in our previous study, cortical atrophy of complex visual and sensory processing areas, the angular gyrus, the supramarginal gyrus, and also the precuneus. And in the functional study, we observed significant group differences between patients in taking the posterior singular cortex used as seat of interest, as the structural study was pointing, and we observed increased connectivity that is shown here in red, and the posterior singular cortex is seen in green, that there was a bilateral middle temporal gyrus alteration in the default, bilateral superior parietal lobe that is increasing connectivity in these areas that again are related with the default mode network and with the attentional networks. That is, we observed the disintegration of intra-network connections of the default and appearance of aberrant functional relationships with these attentional networks. Talking or speaking in the graph methodology analysis or the functional, there was a loss of anti-correlation between nodes of the default and the attentional networks. That is more or less putting together the findings of studies on major and minor hallucinations, the common alterations that is already observed in minor hallucinations is a failure to recruit the dorsal attentional network when interpreting some ambiguous percept, and an overuse of the default mode network during visual processing, when the normal situation is a disactivation of the default. That is, we observed that the alteration of the default is the earliest failure of the hallucinatory phenomenon of Parkinson's disease. But which is the predictive value of this minor psychotic phenomenon? As we said, we observed no differences in patients with minor and no hallucinations. But perhaps this absence of differences, in spite that we observe all these structural and functional alterations in patients with minor hallucinations, are due to small sample sizes or lack of longitudinal follow-up. And then, while we complete our own 5-year results, and we are finishing this study, we went fishing to the PPMI initiative, and we have access to these patients, and we studied 131 patients de novo from this PPMI sample with available MRI, and compared the cognitive outcome at 5 years between patients with and without minor hallucinations during follow-up. And additionally, we studied structural brain differences between groups during follow-up using gray matter volume and voxel-based morphometry. Our results show that 35% of patients developed minor hallucinations during follow-up, and there was an increased prevalence of cognitive decline, that is a clinical diagnosis of PDMCI at 5 years compared to non-hallucinators. That is, patients with or exhibiting minor hallucinations during these 5 years follow-up presented 44% of mild cognitive impairment versus 14% in non-minor hallucinators. In the structural analysis, we observed differences in baseline in atrophy between both groups in the sense of reduced gray matter volume in visual perceptive areas at baseline and increased loss in left temporal areas, again areas related with visual spatial processing. As a conclusion, hallucinations are one of the most disabling symptoms in Parkinson's disease. The prevalence of major hallucinations increases progressively throughout the course of the disease. Major hallucinations are consistently associated with cognitive impairment and dementia, and are mostly related to structural and functional changes in cortical areas of visual processing. An abnormal connectivity between the default mode and the visual system underlines the manifestations of these major visual hallucinations. Regarding minor hallucinations, they are the most prevalent form of visual hallucinations in Parkinson's disease. They appear from very early phases and even can precede the motor symptoms, that is a true premotor phenomena. Neural correlates of both types of hallucinations, minor and major, appears to be similar. Early development of minor hallucinations is associated with midterm cognitive decline, and minor hallucinations predict more extensive gray matter volume loss and an increased rate of atrophy in occipitotemporal regions. That is, minor hallucinations should be considered as a potential predictive clinical marker of cognitive deterioration and increased neurodegeneration in Parkinson's disease, and the mechanism is common with major hallucinations: inability to recruit attentional networks and an overutilization of the default neural network for visual processing. And many thanks. This is my group, and I circled two of the people who mostly contributed to these studies, Elena Beer-Kassen, who is the doctoral thesis is on these hallucinations, and Fred, that is our brilliant engineer helping in all these neuroimaging studies. Thank you very much for your attention.